Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone, welcome to another episode of the Gestalt Education Show. Today, we're in Chesterfield, Missouri, home of the Brett Winchester. We're here at Bluetail Medical Group with Dr. Matt Bays, the expert in this area, the legend for regenerative medicine. So today, it's been a much requested topic. It's we just haven't, our schedules just haven't worked out to finally sit down with Matt. And so, Matt, we're going to dive deep into a little bit of regenerative medicine. You're a partner here at Bluetail Medical Group. You have locations all over, but this is your home. So this is where you live. Yeah. So can you just kind of talk about, just give us a very brief, like, why are you here doing regenerative medicine? You have a pediatrics background, you have a sports medicine background, but like, what was maybe the one story that really got you into doing this regenerative medicine? And then we'll kind of go on to the more the sciencey stuff.
Well, I started mainstream, did a primary care sports fellowship, and was, working with George Paletta and all these guys, and still good friends with them who you've had as a guest. And I have a friend, David Crane, who I'm now partners with at Bluetail, and I just kind of started sending him a couple patients, and I trusted him, and then I saw the outcomes. And so short answer is there's a better way for many pathologies other than surgery. And the key here is, how do you find the right indication in the right patient with the right recipe and the right rehab after to get that patient a good outcome? And I saw it with my own eyes, and then I was like, oh, I got to do this.
Yeah, it's perfect. It's like Gestalt. So Gestalt is literally the sum is bigger than the parts. Yeah. So figuring out that integration piece of how it all comes together. So how long did you start feeling comfortable with this? Like, I know Dave is kind of the pioneer in this, and you're following around, you're telling stories, you're carrying around anatomy books and just following him. Yeah. And that's kind of where you got your start with ultrasound and stuff like that. But at what point did you start seeing like these crazy outcomes and like, holy shit, like this is the next phase?
Yeah, I mean, I joined Dave and Kristen Oliver, who's now retired, but I joined in 2011, and I jumped right in. I had done some PRP before that. I had not done any stem cell, and we'll talk about the difference, but I had done PRP with Dr. Paletta and some of his athletes and patients before that, starting in 2010. And, I was using ultrasound, and I had talked to Dave about protocols, but, you got to figure this out somehow. So when it came time, I just said, I want to join Dave, and we started Bluetail at that point. And that's when I really dove headfirst into, okay, now I'm in. It was like a mini fellowship where I just kind of worked with them and saw my own patients, but really watched what they did, Dave and Kristen. It was such a way to learn. I was so blessed to have that. So, and then over the next 2 years, I branched into adipose as a source of mesenchymal stem cells, and then bone marrow ultimately. And that's where we're at.
I was telling Taylor, I was going to present on this weekend in Nemacolin, Pennsylvania, and David Crane was supposed to present before me. So I was actually really nervous because I knew like his reputation and things like that. Well, he had to bail at the last second. So the Michael Scarpone, he actually presented for him. And it was interesting. This has been a while ago. And he was saying, the only research we have right now is for lateral epicondylitis. But then he said, we're getting miracles with this, like all over the body. Like, what's been your experience with this? Because the evidence is still like on its way, right? It's a little bit lacking, but
I would say agree. It's a lot less lacking than it was. And I don't know what year that was. And
Probably
Michael's
8 years ago.
He's
maybe.
a giant in the field along with Dr. Crane.
Yeah.
Oh yeah. There is reams and reams of great evidence now. Now we need more level 1 evidence, which is ongoing currently at like the big educational academic centers where they have, 150 people in each arm. One gets stem cells, the other gets a sham saline treatment, and which arm does better blinded. That level of evidence is still coming, but we've got a solid level 2 evidence in orthopedics. So it's happening.
So where do you, besides the lateral elbow, what are some other areas of the body that you're like, this is a home run?
Well, I like to think like classify it. I'm a lumper. So think about like tendon versus ligament versus joint versus nerve or soft tissue. I think tendons are home runs, given the right patient.
Right.
And that's one thing I really want to delve in today is how do we know who's going to do well and who's not? So don't let me forget. Yeah. Ligaments do great. Ligaments, partial ulnar collateral ligaments. Dr. Plena and I work a lot together on that and pitchers. Degenerative joints, we know when to say when and say, okay, you need that knee or hip replaced, but we also know who we can help. And we'll talk about that. So probably our biggest indication is knee osteoarthritis by far.
Right.
What in the physical exam leads you towards that then? Like, I know for us, a couple of things we always look at is like a major loss of knee flexion, the crepitus or like the big grinding and things like that. Like those are usually a good indicators.
Varus deformity
in the
As
tibia.
Someone who just needs a replacement.
Or like that maybe headed that direction, like someone that we're like in the back of our head thinking, holy smokes, like this is going to be a tough case. Are there anything that like, you're like, okay, if I feel this in the exam or, what's the extremes, I guess, are the ones that really get better and then don't get better?
Yeah, the grade 4 lateral OA with a lateral or with a varus deformity needs their knee replaced because they'll have a realignment procedure in that surgery. And we saw that in our own data that we've published. The grade 4 medial OA with minor malalignment does really well.
Cool.
And they do great. So we still treat those. Mm-hmm. And I never thought I would do that until I saw the results. And now it's changing people. And we can get right into that. Like, how do we know what are all the factors that we use on patient indication? Do you want me to talk about that?
Well, let's start. Can we just go through all the different services? Like, so the difference between PRP, stem cell, when you're using which one.
Yeah.
And whatever else we're leaving out.
Yeah. So platelet-rich plasma, let's just start there. And I'm going to talk like your audience doesn't know what that is, and 99% of them do.
Sure.
But it's not homologous. So like, when you talk about platelet-rich plasma as someone who uses the machines that we do, we want to know what level above baseline is that concentration. Is it 2x above? Is it 5? Is it 9? Is it 11? And why? Do you have a high white cell count in there with neutrophils and mast cells, or do you try and blow that white cell count down to be less inflammatory? So that's PRP. And so that, you draw the patient's blood and you put it in our machines right behind Brett's head, and we can set the settings for what the indication demands based on our experience. So that's where we say, like, there's a lot of PRP machines out there and they're tabletop and they're cheap and, it's a 10-minute spin and you get your PRP. But I always talk to the reps and I go, well, what is that? And they go, oh, it's a 2.5x times baseline. And I'm like, okay, that's good to know. Is that reproducible? Yes. Okay, but we want more than that. Like, what if I want 8? What if I want 15? Sure. Like, well, we can't do that. And so if you're comfortable with that lower setting, maybe that's a good machine for a certain indication. Does that answer your question?
Yeah.
Yep.
PRP.
Yep. Okay.
So stem cell. We're interested in the line of stem cells called mesenchymal stem cells. That is the certain cell versus hematopoietic, which creates blood cells. Mesenchymal creates more connective tissue like bone, cartilage, ligament, tendon, adipose. And so we get that from bone marrow primarily. So we can do an in-office bone marrow aspiration. I did 3 of them today. This is my table right here. We make the patient very comfortable. Right behind me, you guys can't see, is a laughing gas machine. I've come up right on my 2300th bone marrow this month. I've never had a patient, knock on wood, that has said, please stop, that hurts so bad, I can't handle it, and I'd like my money back. It doesn't happen. So if you do 2,300 of these, and Dave has probably done 15,000, you see the toughest people, you see the weeniest people. Sure. The weeniest people get through it just fine. It takes under 10 minutes. We're super sterile. We're careful. We're measured. We draw about 90 cc's of bone marrow out. We put it in a machine. It then concentrates it down based on our setting, like I said. And then we can give, like, we know the standards of the machine. We can give X number of hundreds of thousands of mesenchymal stem cells. But that's not culture expanding it, which, as we discussed earlier, the FDA does not allow you to do in this country. So we're very within the FDA parameters for that. And then we're spinning it and injecting it very carefully using ultrasound into the indicated.
And how do you triage, Matt, to know like when to use which of your tools? Like, how does that all?
Yeah. So let's talk about adipose. I left that out. So adipose is a great source of stem cells. Adipose actually has more stem cells per volume of native fluid, like, X amount of cc's of bone marrow versus adipose, but you can't concentrate the adipose at all. It is what it is. But the thing that adipose has is a structure. If you think about fat, it's like toothpaste. So it's a semi-solid. Toothpaste is a great analogy. It comes right out like toothpaste from a syringe. That has a matrix or structure that gives you some scaffold to kind of glue tissue together, in a rough analogy. So I treated a patient today that had partial MCL tear, right? So if those linear fibers, I'm going to try and hold this up for the camera, linear fibers of an MCL are, instead of being together, are split. Well, not only do I put stem cells in there, I put adipose in there, and that adipose stem cell creates a scaffold or caulk or glue, which helps seal that together. And we like to use that for partial tendon tears, partial linear ligament tears.
Perfect.
All right. So did that answer the
question?
Yep.
Yeah. Beautiful. Yeah. Yep. So then, what when you're working up a patient, a patient comes in today with knee OA. What's making you decide which one you're going to choose?
Yeah. How do we do it all? We insist on a weight-bearing x-ray. We have an x-ray here. So we want a 4-view weight-bearing x-ray. That'd be a huge piece of advice that I could give to any young clinician who's ordering x-rays, is make them weight-bearing. Because time and time again, we see outside films that are not weight-bearing. And when they're laying down, gravity isn't working. So you stand them up and you're like, oh, look at that joint collapse. So we want weight-bearing x-rays. We do diagnostic ultrasounds. We look at the pes. We look at the popliteus. We look at all the soft tissue around the joint. We look at, like, say, that medial femoral condyle bone spur. And if it's pushing up like a stalactite, I can't remember if it's mite or type from below, but if it's pushing up on that capsule, which is rich with nerves, if this is a bone spur and the capsule's going over it and it's stuck on it, and every time they flex their knee, that rubs, you got to get cells in between there. And how do you do that without an ultrasound? So then we want to put fat in there as a pillow, literally. Yeah. And stem cells and PRP. So ultrasound, diagnostic ultrasound helps inform our recipe. We pay a lot of attention to the patient. And if it's okay with you, I'll branch off into that.
Yeah.
Like, throughout the course of the last probably 10 years, we paid a lot more attention to our outcomes. And one of the things that dictates that is it's the patient more than the joint. So if I see a 60-year-old patient who's a heavy smoker, diabetic with a bad A1C, overweight, hormonally not optimized, on a statin, on a bunch of medicines, unhealthy and poor emotional health, I don't care how good their knee is, their outcome isn't going to be great,
right?
Because they've led a life that will now pay back what they've done to it. Take the opposite of that. I see a lot of people in their 70s that act like they're 45, and I see them all the time, and you guys do too, right? Like, you can see when they walk in the room, they have a facial energy, they have muscle tone. We pay a lot of attention to hormone, but when they're taking care of their body, maybe they have diabetes and they're doing their best, but their A1C is well controlled. Maybe they need a blood pressure medicine or a low dose statin, but they're working out and their BMI isn't huge. Their vitamin D is good. They might be on HRT, hormone replacement, which is a big predictor of success. If they're taking care of everything they can, they're going to do well. And those are the people that we'll treat. And that informs our recipe then. Like, hey, we may need more cells in this patient. We might tell this patient, hey, I'm happy to treat you, but you're not as doing as well. We create an algorithm for like a score for our patients. And if their score isn't very good, we might say, hey, at 2 months or 3 months, we want your outcome to be X, Y, or Z, but that's not as good as it could be. So we may need to come back with a second treatment, or heaven forbid, we might just say, I'm not your guy. Go get that joint replaced. The sad news is when they can't, because their BMI is so high that the surgeons won't operate, or they're unhealthy and they won't operate, then they're stuck.
Because it doesn't make them a good candidate for the replacement.
They're not a good,
they're not a good candidate for anybody. Us, you,
yeah.
What about, what's the role of cortisone? Are we still using cortisone injections? Are you still do you make a decision when,
Yeah, I certainly depends on the pathology. So I am very much against cortisone in any tendon. And I've seen Major League Baseball players with an Achilles tendon that was a hollow tube, and in the middle was a space filled with cortisone crystals. And when I had him flex his foot up and down on ultrasound, I could see the white crystals shoot back and forth.
Yikes.
Not great.
Right.
So he had probably 10 steroid shots, and back in the 90s, but still, he was late in his career at that point. So I don't do them for tendons. I will do them for like a subacromial bursitis above the rotator cuff. Mm-hmm. Very careful though to keep it out of the tendon with ultrasound. For joints, if I have a patient who I know and they just want to go to Italy for 2 weeks and not worry about their knee and have an anniversary trip of a lifetime, I'll give them a steroid shot. That's no big deal. But they are cumulative. The more you get, the less effective they are. We do know that causes cartilage injury long term, not short term, but long term. So if they're getting up and in age and they get 4 shots every year, well, that's a ticking time bomb to not working. So we got to pivot to something more effective, be that viscosupplement with hyaluronic acid versus autologous stem cells versus, unloader bracing, all the other stuff, certainly good chiropractic and physical therapy, ultimately a knee replacement.
Sure. Right. What about, so we kind of talked about, didn't say systemic inflammation, but basically systemic inflammation. But what role is the PRP, the stem cells, playing in inflammation? Is that the actual mechanism? Is it just creating, you're getting rid of the inflammatory response, or at the cellular level, what's actually happening when you inject it into that osteoarthritic knee?
I think it's causing a pro-inflammatory response in terms of the healing inflammatory response, as opposed to the pro-inflammatory response, which is IL-1 beta rich, MMP rich, all these degradative cytokines that cause pain and tissue damage. That's bad inflammation. Yeah. We cause good inflammation, no doubt. We cause pain in our patients. I talk to them about medical cannabis all the time. I talk to them about, we give a short course of pain meds when I treat a patient, especially I treat a 70-year-old today with a statin-induced Achilles partial tear. She's going to hurt. She's in a boot with a wedge and she's on hydrocodone tonight. Mm-hmm. And I talked to her about cannabis and she didn't want to do it. And that's fine. But so inflammation is good. We want to direct it in the right direction, which I think PRP does. Think of platelets as the quarterback of the team. So they're going to that's Peyton Manning at the line, Omaha, mm-hmm. Mike, that's super nerdy. But, I'm a big Peyton Manning fan. But so that's the platelet saying, hey, we're going to go in this direction and cause this chain reaction of inflammatory healing. And that's a good thing. Mm-hmm. Now, you did mention inflammation first. And one thing I do want to touch on is, what about autoimmune patients? What if you have a systemic level of inflammation in your body? We draw CRPs and ESRs on our patients. And if they have a healthy dose of underlying inflammation, did you know that? Is this being treated already? Are you a hidden rheumatoid patient? You forgot to put your meds down. Or B, do you have an unhealthy gut biome? And do you really need to get a functional medicine eval and look at that? And we're big believers in that. Yeah.
Would you still go on with the procedure?
Depending on how bad they are.
Right.
I will halt that. If they're like, I didn't want to mention it, my wrist is always hurting. You're looking at their elbow, they've got psoriasis plaques, and they don't go to the doctor. Man, you're swimming upstream if you think PRP in a degenerative joint is going to help that. And they've got the chondrocalcinosis of that, that whole body inflammatory condition. There's a lot that needs to take place. So yeah, I'm way more of a whole body doctor than I ever thought I would be when I went into sports medicine.
Are we all?
Yeah. I wanted to get away from it. But you know what it is? It's which doctors care enough to ask that question, right? And which of us care enough to take that next step. And oftentimes it's not with me, but I know where to send you.
Right.
I don't actually hormonally optimize the patient, but I do know who does. And I'm a believer in that. Or, hey, guess what? You have a goiter and you thought you just had a chubby neck. Let's maybe go to a different primary care doctor because your doc is using out of date standards and your TSH is is sky high, and let's get that in check and then come back.
Yeah.
Well, I think it affects your batting average too, right? I mean, like especially if you're doing research and
selfish, right?
you want to pick the people that you're gonna, do well with,
But still, I 100% agree, Brett. But my favorite patients are the people that haven't had someone pay attention and are floored by the fact that I would run late because I'm interested in their medical care and their psychosocial health, which is super nerdy.
Mm-hmm.
Don't you guys believe? Like, we all need a secondary degree in counseling.
For sure.
God.
Not only for myself.
Oh, yeah. Yeah. That's
like, we could counsel each other, but
that's why we have a full bar in our doctor's
right. Like, so much of what we do is based on if their psychosocial stuff is out of whack, come on. Now, I'm not a therapist. I don't play one, but if you pay attention and ask the right questions, I mean, it gets a little hokey, but yeah, it's important.
No,
I joke, at the end of the day, our patients feel better and we feel like shit because you just taken on all of their shit throughout the day.
When I get home, I have a rule. I will talk on the phone with a patient or a doctor or whatever, whoever I got to call, but I need 5 minutes at the end, and I need like some Phil Collins, or I need Dave Matthews, some food, maybe a little Beastie, and I got to chill before I get in the door.
In your garage.
Because I used to pull into my garage on the phone and walk in, and my wife would be like, turn around, because you got 3 kids here looking at you. You got a dog who wants to play catch.
Right.
You got to take care of yourself.
Like Chris Rock says, can I get my foot in the fucking door? Like, it's that same thing. Like, the second you walk in, it's just like...
We run out of empathy, and then we're bad people, but we're not.
Or like your spouses, we always say, you get home, and maybe they haven't talked to people all day long, maybe they have. But anyways, they're ready to talk, and you're just like sitting there like in a coma. It's like, if you see 35 patients a day, you've literally had 35 appointments and the pressure of making them feel better, and,
Do you ever feel like a cortisol junkie? Like, do you ever have a day where you kind of it's a little slow and you're like, where's the action?
Oh, for sure.
Yeah.
You get cancellation. You're like, what is going on?
I'm a cortisol junkie.
Yeah.
We like it chaotic.
I do, for sure. Yeah.
My staff does. Day goes faster. Everyone's brighter.
Yeah, for sure.
There's 2 cancellations in a row. I'm like going to ESPN.com.
Yeah.
I'm like, the Cardinals lost. What else is new?
Yeah, right.
So how does like the serial set of events go? Meaning, like, is one building on the next? What's the advice to the patient? Are we bringing them back?
What's our process?
Yeah.
So we kind of spend a lot of time, and our staff is brilliant. We've trained them to have these talks with us. We talk about that first 3 days of pain. Really, it's 24 hours, but I'll say 3 days to make it, safe. Is they're just going to work on range of motion and just get comfortable, and you're in for a wild ride that first 24 hours typically, especially with a tendon. And then that, they're going to be back to normal by about day 7 or 8, where they're just like, whatever. And if you work at a desk job, you could work at a desk job the next day if you're adventurous, or maybe take a day off and then go back day 2. I just saw a guy today with bilateral elbow pain, medial and lateral. He's a laborer. He's a construction guy, 48, my age, not unhealthy, skinny, wiry, but he just hurts from like grouting and constant like holding it up to nail it. I was like, buddy, I'm going to treat your elbows, both sides. You're going to be an invalid for about 24 hours. Like, I don't know if you can wipe your butt. Right. I go, are you married? He said, yes. I go, your spouse, and you have to buy this person dinner. And a week later. But like, he's not going to go back to work for 7 days, because I said, I can't imagine you can swing a hammer. But he's also providing for his family with his job, and he needs that income. So I was like, all right, we're going to whittle this down to day 7. Plan some easy jobs. He makes his own schedule. He's his own company. And I was like, do some easy jobs for about a week. But so we start back in some formal therapy at about 2 weeks. Strength, range of motion, baseline, right? Just get some measurements. Great talk that we should branch into. What is the role of interventional therapy post regenerative medicine? Fascinating topic for me. All about passive chiropractic, meaning mobilization, stuff like that by that. When I talk to guys who do like ART, Graston, deep tissue, dry needle, interventional more is what I call chiropractic, and some therapy, but they don't do as much, some dry needling. I don't think there's a great role for that in the early time after the injection to the site of pathology. Right. Like if it's a knee or if it's a quad tendon, let's say it's a quad tendon and there's a partial tear and I just did adipose and bone marrow. Well, we don't need a dry needle in there. Probably, maybe for a real long time, if not ever. If you want to dry needle proximal to that, or if you want to dry needle the vastus coming in, and I treated more of the medialis, I get that.
Yeah.
But like my understanding, please correct me if I'm wrong, with all, humility, the role of those interventions is to create microtissue trauma, create blood flow, create vascular permeability, ergo stem cells come to an area. It's all the same. Like I always tell people, hey, if you can't afford a stem cell or PRP, let's find you a chiropractor or a physical therapist that can cause some mini tissue damage, which will cause better healing. I mean, the advancements in chiropractic and physical therapy are insane. Like that's maybe better than an old whole blood injection, which is what they did before PRP, before my time. So there's real value in that. But right after a treatment, I don't want to do that to the site of injury. But like, let's say you want to dry needle the IT band, like be my guest. Sure. So then at about I kind of chunk it into months. At about 2 to 4 weeks, it's just going to be kind of like, again, just work on your range of motion, make sure the gait's good. If it's a lower extremity injury, if it's an Achilles, we're way slow, or plantar fascia, and that or patellar tendon. And then from week 4 to week 8, so like starting of month 2, then it's going to be all right. Progressive loading as tolerated. Careful with the eccentrics. Be careful. Like we're not doing high level hamstring loading if you treated a hamstring tendon. Common sense stuff that you guys would get. And then the patient will notice they're getting stronger. They won't really notice that, like, let's say they had a bad patellar tendon and they hurt to go downstairs. Of course they did, right? Because that's the highest load to a patellar tendon, or jumping. Well, we're not going to have them jump yet, but they might between week 4 and 8 say, stairs hurt less. Like I feel better. We see them back at week 8 for the first visit. If everything's going well, they have a scheduled visit at week 8. We look at the tissue with ultrasound, but it's kind of, to make them and us just feel better. We don't see change on a big ultrasound. It's microscopic. It's cellular, right? So you can't, I can see, in a partial tendon tear, I can see that I filled that with fat and I didn't leave a hole. That's important. I can see that. Other than that, or like a degenerative knee, yeah, it still looks degenerative. But by week 8, we want there to be significant pain relief and function improvement. It's just the start, though. Between 8 and 12, that's when their gains are made. So let's say we have an endurance athlete who's a runner and they have a, like I have in this ultrasound, we can look at it later. Horizontal cleavage tear of the medial meniscus, 57-year-old healthy, fit lady, couldn't do her exercise classes. No kidding. She had medial knee OA, mild, moderate. So I want her between week 8 and 12 to do smart exercise. I want her on an elliptical. I want her certainly biking and swimming, could have gone long before that. And then we want to start considering interval walk run, low level. And I don't really think this woman should run a lot the rest of her life, jogging, marathons. But could she incorporate that into some HIIT classes? Yeah, probably, smartly. And then I see him back at 3 months, which is the 12th week. And then the rubber hits the road. It's like, okay, how are you doing? You should have a very good idea of how you're going to do long-term by week 12. And then we can pivot as needed. Do you need a second PRP? We call it a booster shot. And there's a role for that in many, many people. We think it really helps our degenerative joints like knee OA. Our patients who get a PRP booster do better longer. So our data shows, I'm all over the place. Is an ADD mind at work?
You do good.
Okay, good. Hopefully people are keeping up. When we treat knee OA, our standard speech, you're going to get a glimpse of how you feel at 8 weeks. You're going to really know how you feel at 12. And then we're going to talk about what is the role of PRP after a stem cell with PRP. It's called a booster shot. Much less expensive, much less invasive, much less painful, much less recovery time. But those people who do that last longer. Our 5-year outcome data shows us that we can get 5 to 7 years of relief. We think it'll go 7. We're waiting 2 more years. That'll be about 8 months before we get that data. We can get relief. VAS scores are statistically significantly better. WOMAC scores are, and these are all orthopedic, science, validated outcome scoring for knee OA. Our WOMAC scores are better for pain, function, stability, and activities of daily living. That comes down by 3 months, kind of plateaus at 6 months, holds for 1 year, holds for 2 years, holds to 5 years. No kidding. Wow. That's cool. So if someone comes in, so now how do we talk to patients about that? I say, if you have a great outcome, we're going to get you 5 years of knee pain relief, because that's basically all I can say right now based on our data. Nobody else has long-term data like that, like we do. It just hasn't been done. Now, if you start to factor in health status, age, morbidities, all that stuff, demand, like let's say they want to run an Ironman. I don't know if you're going to be running Ironman with a bad knee OA we got to have common sense. But then we say, okay, then you come back. And if this works the first time, you're 5 years older, you're not 105, we can treat you again. You don't have to get your knee replaced. Now, if you get 4.5 years of relief and then you're in awful pain and you don't want to go through the stem cell again, or you don't want to pay for it, well, let's talk. What are some other options? Could you get a partial knee replacement? Could you just get a knee replacement and do better? We know the outcome of knee replacements. There's huge meta-analysis. 1 in 3 patients are unhappy at 1 year with their outcome. 0.2% of patients die on the table. This is all-comer patients, all-comer doctors, all-comer hospitals. Mm-hmm. So, of course, like the people we use in St. Louis that are the best, that's not their data. Like I encourage people to get their knee replaced when they need it. So, but it's an informed discussion you got to have with your patient. I'm sure you guys do. Mm-hmm.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brett Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Parker University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
I'm off topic.
What do you think about, so some of the tendon researchers in the world, like Kareem Khan and Jill Cook, like in our world, it's interesting because like they talk about stories where, you have a patient who's got a very painful tendon. They go through a rehab program on ultrasound, like mucoid degenerative change, whatever. It doesn't change, but the patient's doing better. Mm-hmm. So do you think like that some of these benefits are like neurophysiologic, or do you think like you're actually going back re-ultrasounding and seeing like a complete change in the tissue? Does it matter?
Yeah, it does matter. But I will say, you see this, I'm sure, that the patients do better than the visual.
Right. Yeah. Exactly.
When the patients do better, the visual lags way behind.
Yeah. In everything, disc hernia,
Always. Yeah. So younger patients with like discrete injuries, I want that tendon to heal. I'm not saying you get a 5-year response with that. That's more degenerative. If I have a young pitcher with a partial UCL tear, I want that to heal and then never to have another injury, God willing. If they've got that
you're
mixoid,
using the ultrasound like as an objective thing to come back to and that's just built into the system kind of.
Yep.
Yeah.
Yeah, always. If they've got that degenerative statin-induced tendinopathy, I mean, famous like guys our age who are on, 40 milligrams of atorvastatin and they wrenched their Achilles mowing the hilly yard. I see that all day long. By the way, they're a bit of a smoker. They like cigar too. That's sad, but like I'm never getting that tendon to be perfect. Mm-hmm. But most 50-year-old male, I've lived a life tendon don't look perfect. Mm-hmm. Like if we ultrasounded my rotator cuff, I'm turning 48 this month. I'm sure there's some stuff in there, but I don't feel it. Mm-hmm. So we take everything, together. So I base everything. I will say my priority is patient outcome and patient expectations first. Second, how's that visually look? Way behind that.
Yeah.
Yeah. So I don't get caught up now, if it's a big tear, I want to see it, come together. But they wouldn't feel good if it didn't.
And you developed your reputation getting people back on the field. You haven't developed your reputation telling athletes to rest, obviously. So, but your timelines.
No, we have people who hate us.
But your timeline. So, I mean, you're talking like 4 weeks and things like that. So when you're working with, let's pick baseball. So you got an oblique injury. We got people that were trying to rush back on the field. Does your timeline change? I mean, the mistake that gets made in our field all the time, people don't understand like tissue healing. So like you were giving an example of dry needling. Well, if you're pitching tonight, well, 2:00 today is probably not a great time to play around with dry needling. So I think people like don't understand like the inflammatory stage. Sometimes we're purposely putting people back in the inflammatory stage. We have a repair, we have a remodeling phase, and people like they want to cheat that. So working with the athletes, I mean, does it change for your athletes versus the examples you were given before, or is it case dependent depending on like what you need to?
Yeah, it certainly is. We're not biohacking and cheating the whole repair process of the body,
right?
But we can speed it up.
Yeah.
So there is some answer that I agree with where we get athletes back quicker, but it's all within reason. So like, when we treat a professional baseball player, they're still on the
aisle. Yeah.
The aisle, they're still out, but that partial UCL where, we're just going to rest you for 3, the old protocol, rest you for 8 weeks, and then you're going to go down to the minors and try and pitch. And if you feel good, then we'll advance, and then they come back and they complete the tear. They get bad. Now you're out a year and you just wasted, 12 weeks. So what we do is we get people back, like for partial UCL, it's, rehab your shoulder for the first 4 weeks, leave the elbow alone. Weeks 4 to 8, start to kind of like mobilize the elbow, but let's just basically range of motion. Make sure the glenohumeral internal rotation deficit is solved. Make sure the core is good. Make sure everything else is important and doing well. And then starting at week 8, I would repeat the MRI. UCLs, we still use MRIs. We want that dye in there. Mm-hmm. And if that shows resolution of edema, then they start a long toss program for 4 weeks to probably 2.5 to 3 weeks long toss, and then 4 weeks on the mound. So if you do the math, it's like 8 plus 2.5 is 10 plus 4 is 14. That's 14 weeks back to pitch, right, all day long. That's pretty good for like a partial UCL tear.
Right. And then like, so your stubborn, proximal hamstrings, your oblique injuries. So the benefit of your services are basically trimming down the recovery time, or helping with the thought that maybe you're preventing the problem in the future.
Yeah, I think what you're doing is we're improving the recovery time because you're improving blood flow and putting the reparative cells to the pathology. But more importantly, you're not healing with that fibrin and that connective tissue kind of like rough heal. You're laying down native cells, which are going to form the correct collagen, be it the tendon or the hyaline cartilage. So yeah, like an oblique is a great example. I hate oblique injuries.
Oh, same.
They're awful.
Yeah,
it's always
awful.
February and March in baseball.
Yeah.
Welcome to oblique injury season. Or October, I guess, in late baseball. But, it definitely still helps. I'm sure of it. Hamstrings are one of my favorites. Hamstring tendons in athletes, they just don't seem to get the blood flow that we think they get. And that's where I think like you got to have a strong freaking thumb for you guys in a runner's butt to get that hamstring tendon, right? But release it, get that. If you guys, I feel like a lot of therapists that are good with their hands can get hamstring results. And then if that doesn't work, I put a needle right in that sucker. And I love them because surgeons don't want them. There's not anything to put together. If they're pulled away by 2.5 centimeters, they got to have it put it back. We all know that.
Yeah.
Even if they're pulled away by less than that, I will still treat those. And this goes back to your first question. What does it look like after? There's fat between the tendon and the ischial tuberosity, but that's not tendon, and they feel great. And more often than not, they're isolated hamstring muscle testing in the expert's office, like therapy guys or gals. They're like 85, 90% of their native side. I mean, it's crazy.
Yeah.
And that I think is more neuromodulation. I really, really, really do think that early on in the injury, they're in so much pain. They can't recruit any other muscle. They're just totally haywire chaos. When you get that to calm down and you do have some healing taking place, but those nerves are now flossing well, they're firing normal, they're not going crazy, they recruit muscles normally, they recruit all those accessory muscles, and what other hamstring they have left, if it's the lateral band or the medial band, whatever, now it fires.
Yeah.
I mean, because I don't know if you see a lot of hamstrings where you have an MRI and you're like, there's no freaking way that high grade partial hamstring tear just healed in 4 to 6 weeks if you guys get them better like that, which can happen. I see that non-injection wise even. Oh, you did. You got them better. You like neuromodulated their hamstring. Mm-hmm. That's real.
What do you think about, I mean, there's crazy stories of like full thickness ACL tears through regenerative medicine, like the two ends finding each other. Like,
it gives me the heebie-jeebies.
Yeah. So
it scares the crap out of me because, okay, well, I'll just come out and say it. You had George Paletta on, and I loved the episode. George Paletta was my second orthopedic surgeon boss. Mike Milne hired me first, and then probably within a week, George was like, "Why don't you work for me too?" And I was like, "Okay, yes, sir." And that was the start of just a great friendship and great professional collaboration. But you know, God, what was the question?
ACL.
ACL, like
non-operative ACL.
Thank you. Bird.
Yeah.
I was trained by Dr. Paletta to be very, very
skeptical,
healthfully skeptical of stuff. I don't believe personally that two dwindling ends of an ACL with the frayed rope that we all see go like that. No, absolutely not. But like if it's here and this side is partially torn or fully torn, part of it, I think that could happen. It has to have a way to get there.
Right. Just like biomechanics makes sense.
If you're walking and moving, those ends are never going to come together. Now, I do think there's great data that shows in a full ACL tear, if someone doesn't want to have surgery, which if I will talk them out of that if they're the right patient. If they're young and healthy and want stability and avoid that post-traumatic OA, you need to have surgery. But if you're 55 and you're like, look, I'm not trying to ski, I'm not trying to play soccer, I don't want to undergo that surgery, I understand the risk of arthritis. A stem cell within the joint and to the capsule, if we stabilize that outer capsule of the knee through stem cell injections, that provides a significant amount of stability. The ACL is rotatory stability, it's anterior posterior stability. You know, the capsule can provide some of that.
What role does bracing come into play with that? Like, are there any cases that you'll immobilize after injecting, or is everything just continued weight bearing to tolerance afterwards?
I do brace. So I would brace a partial ACL. Tomorrow, this is an interesting case. I'm doing a 19-year-old bilateral proximal patellar tendon, just bad tendinopathy, which if you call it bad tendinopathy is a partial tear if you look with an ultrasound or a good MRI. So this is a very competitive ultimate Frisbee player. And he's just played with this for 2 years. And finally last spring, he had to pull himself out of games. And finally his parents were like, what are you doing? Let's do something about it. He limps around. He's 6'4", 180 pounds. He's just like a gazelle. He's one of these jumper runner guys. So tomorrow I'm treating him and I'm going to do bone marrow and PRP. I don't even think the guy has any fat. So I'm not going to take crappy fat and try and put it in there. I'm going to lock him in an extended knee brace at 0 for about 5 days, which 2 knees and a locked knee brace. I had to talk with his mom tonight. She's like, how does he go to the bathroom? And I said, within reason, you're going to take these braces off and he's going to try and sit down with as little bend in his knee as possible. I'm not, a masochist. When he takes a shower, he can take the brace off. I want him to sleep in the brace. Yeah. And then on day 7, he's going to hinge to about 30 of flexion, which is more than we think. That's pretty comfortable. You can walk with 30 with, some limp. So the first, he's going to be like, he's going to be like a robot walking without bending his knees. He can weight bear. He doesn't need to be in a wheelchair, but there is limited times where we will brace. I don't even brace my UCLs.
Sure.
Because I just say, don't do like valgus stress, Motion is the lotion. We want you to move.
Yeah. And then you mentioned the Achilles would be another one that you may do that, like a partial tear of the Achilles.
Yeah, Justice, 70-year-old, like I said, statin induced, and she's in a long boot with a heel wedge. And then every 3 days we take one of the wedge pieces out, so she's slowly lengthening down. And then by day 11, she's out of the boot. And so I'll put them on I just use a knee scooter now.
Sure.
They love it. I don't know if you guys...
Just easier. Oh, yeah.
It's so much easier to get around. My 10-year-old broke her leg this spring, and she was getting around faster than I was just in a knee scooter. Yeah.
Shock our listeners with some things. We've talked about, medial lateral elbow issues. We talked about UCL. What are some things that people aren't really thinking about with regenerative medicine that you're doing and you're noticing like amazing results with that maybe people don't know about?
Great question. I'm kind of like daring myself. How honest do I want to answer? Yeah. Because there's some cool stuff.
Like we struggle in our world, like with, for example, like the wrist joint. You have 9 tendons, a couple nerves, no local muscle system. The joints are hardly ever restricted. So like all our tools kind of go away. Like AC joints, another good example.
TFCC, yeah.
Love wrist. Wrist is one of my favorite things. My favorite case is when I was in the military in South Carolina, my piano, like my director of the band and orchestra and piano, really accomplished classical pianist, is this 74-year-old great guy, and he kept in touch with me. And we moved back to St. Louis when I did my fellowship. And then he found out somewhere I was doing stem cells. He's like, can you help my arthritic wrist? He flew to St. Louis. I treated him 5 years ago with one stem cell treatment with PRP. His range of motion came back with appropriate hand therapy, and he is in this position now, back playing classical piano. I love degenerative wrists because think about like the surgical options for them are bad.
Yeah.
Suck. Yeah.
Like they'll take bones out. Yeah. They'll shorten the ulna. They'll end up fusing. You cannot play a piano with a wrist that doesn't flex and extend or ulnar deviate. So great low expectation for that patient because they're like, I got to have my wrist fused. And I'm like, no, you don't. We can help this. And we that's probably a great answer to your question is wrist OA does really well. I will also say it's probably the most painful thing we treat. And we do learn, I think I overloaded this woman. I treated a woman who is a ex-CIA agent, lawyer turned power gym, lifting gym owner.
Gosh.
My age. Like I was terrified of this one. Nicest lady in the world. I actually drove to a Walgreens with a script that night because the hydrocodone wasn't enough. I had to give her some Oxy. She was in that much pain, and I was on call that night, and she was like really honest. She's like, "I'm dying here," and I was in the CIA. Like, please help. And I was like, I'll go to your pharmacy. We'll write you a script. It's the first time I've ever written Oxy in my life. Right. I was like, wow.
Right.
But after that flare, they do great. I was gonna say. With the orthopedic surgeons I work with, I'm so blessed to have such good reputation or a relationship with a lot of different orthopedic surgeons. They're now sending me these like isolated, full, non-retracted rotator cuff tears in middle-aged people, like in like the 30 to, on up, because no one wants to operate above 60-ish.
Right. They
do bad. So they send me all those. But if there's half of that supraspinatus left, and it's always the posterior half. You got to think three-dimensionally when you're talking about any tendon, but specifically the rotator cuff. It's 2.5 centimeters from front to back, and I always go like this. It's 2.5 centimeters from front to back, but it's also like 1.5 centimeters thick, superficial to deep. All right. And it's three-dimensional. So always we see something about the way God made us is the front of the tendon is what tears, but the back half to 2/3 is usually solid. Well, that's acting as a graft for that injured tendon. If I put those cells right there, it can grow along that map of the posterior half, and those do great. Definitely needs attention afterwards. Like when I see patients like that who are like, I don't like to go to a chiropractor or a physical therapist, I'm like, then you're not going to do well. You got to suck it up and do the work. Those are great. I was going to say, we don't need to talk about it, but like sexual medicine is an amazing thing. Think about like what stem cells do. They improve blood flow and help tissue grow. So if you have erectile dysfunction, most of it is, and we all like to joke about it, but it's an awful thing. And if you have a diabetic, loss of function, if you can get some angiogenesis and then here comes the nerves afterwards, our success rate with that is huge. Or if you have like a post-radical prostatectomy nerve injury, we've had some really nice outcomes with that. The pelvic floor dysfunction in women with urinary incontinence, like everyone, it's such a fallacy. I don't know how much pelvic floor. You had a pelvic floor therapist on.
Oh, yeah.
And I saw the title. I really need to listen to the episode. Women who are after childbearing age, it is not normal to leak urine. And we have taught, our society has said, after a while, when you jump on that trampoline, you're just going to leak, or if you jog, you're going to leak. So after about 50, you're going to wear a diaper or a pad. And then after 70, you're in diapers. Okay, that's not acceptable, right? So attack that from a pelvic floor eval. Vast majority of those get better with that. Urologists don't know what to do. The mesh isn't great. The surgical procedures, some of them work, some of them don't. And when they don't, it's a mess. So buffing up that periurethral musculature and tone, both intravaginal and extra. You know, we have people here who do that, and there's some amazing outcomes in my own patients. I don't personally do that, but I know where to send them, and that's awesome.
What about sports hernia?
Hate it. Hate everything about it, start to finish. I'm just being really honest. Yeah. It's such a muddled, like if you would ask me, what is the one thing that intimidates me 15 years, 14 years after getting out of fellowship, you know, because everything intimidates you when you're young.
Yeah.
You don't even know what you don't know. And then you realize what you don't know. And now you're like, okay, I'm getting smarter, but I know what I don't know. I still fear athletic pubalgia because there's about 8 things that could cause it. And you got to be smart enough to like find it and rule it out. And I think I am, but it's hard work. Sure. And it's very patient dependent. So like, is it a small muscle tear at the insertion, right? You know, either transverse or rectus or iliopectineus or I don't even know.
One of the
like it's so crazy. That's why I'm good friends with one of the reasons I love Rob Hagan. Do you guys know that name? He's a nerve surgeon in St. Louis. He would be a fantastic guest for you guys. He's a peripheral nerve expert. He's a Union, Missouri boy. He's a cattle farmer, so he grows Wagyu beef. We're about to go crush some steaks tonight, right?
Yeah,
I hope.
Yeah.
I've never even had Wagyu beef, by the way, because I can't afford it. But Rob has a cattle farm in Sullivan, Missouri. I say that because he's a Union, Missouri boy, you know, born and raised, went to SLU. He's a couple years ahead of me. Oh, by the way, went to Women's and Children's, Brigham, whatever hospital, Harvard, got his plastics residency, hand surgeon, peripheral nerve surgeon.
Interesting.
He's the most humble, hilarious guy you'll ever meet, who's probably a genius.
We got to get him on.
And for bring your peripheral nerve, and I want to sit in the room when he's there because like when he's like David Crane. When they talk, I learn. I just kind of like shut up for the first time in my life and I just ask a question and then listen.
We might have a seminar we could have.
Yeah,
be
there
a part
you
of.
go.
Oh, he'd love it too. He lectures internationally. Okay. So anyway, he's the guy, like he'll do the iliofemoral nerve block in some of these patients and be like, you know, I'll send him to him first. I'll be like, can you roll out a nerve? Because I don't do a lot of those nerve injections. I do like easy carpal tunnel, cubital tunnel. You know, I don't mess with the brachial plexus or like any pelvic nerves. It's just not my area. So he can do all that stuff and either rule it in or rule it out. And if he rules it in, like maybe there's some scar tissue there. And he, like, you know, that neuralgia paresthetica.
Mm-hmm. Oh, yeah.
We love it, right? It's the tight blue gene, right? Mm-hmm. It actually is real. I've seen it. And I've sent them to Rob. He releases the little fascia over the nerve. And they're like, I'll be damned. I can wear my whatever brand of tight jeans they want to wear.
Brett can wear the Wranglers again. So.
Yeah, Brett
skinny jeans. That's right.
With a belt buckle.
Yeah. What about, I mean, the elephant in the room on regenerative medicine is cost. So what would you advise us telling the patient, like, you know, ballpark? Because people always want to know, like, what is this going to,
No, and whenever I talk to groups or do a podcast, we do need to talk about that because it's real. Like, people need to know.
It's a barrier.
Yeah. So it's not covered by insurance. We could spend an hour talking about why, and I don't really even know, but I don't think they're motivated to do the right thing for their patients. So I don't think they're going to cover.
Well, hopefully they never do cover it. I mean, because you'd be...
Well, I mean, I think I would still make a living.
Yeah. Oh, yeah, you would.
It would certainly expand the scope of patients that could get it. That's a good thing. I mean,
it's like the dentists now regretting that they ever, you know, got into it, you know, because, But anyways, go ahead.
The best ones don't take insurance.
Yeah, exactly.
Sure. So first of all, when you come to our office, we take almost every insurance. So when you see us for an evaluation, we're going to spend as much time as we need to get a diagnosis and talk about treatment options. That is under insurance, so don't be intimidated. We have a listing of our prices. You'll see it there. Like, we can talk about what that means and what each option means and which one's right for you. So for a standard PRP, it's below $1,500 to get that, and then again, we quote our patients like we're 90% sure this is going to get you better if we decide to do it, whatever that is, whatever it is. For stem cell, that's much more involved. It's about twice that price. And that's, again, we're not going to treat you unless we're 90% sure. So our single most important job and why we started tracking our data was to figure out who we can't help and avoid treating them, because no one likes that. Nobody likes it. And I like it worse than the patient when they come back and they go, I'm sorry, I'm just not better. And I'm like, no, I'm sorry, you're not better. We do have a payment plan. We try and help people. But there are certain people that just flat out cannot afford this for sure. And that's hard.
Yeah.
Yeah, I think having exclusionary criteria is huge. Like knowing who you can't help instead of, we can help everybody. So, I mean, I think that
it goes back to that. We call it the Regenerative Matrix Index. I kind of hinted at it. It's a kind of a score we give our patients. So it's as objective as we can be based on the data that we glean. We also created this whole functional medicine program. Like we have a PA, Raquel, who runs our healthcare optimization program and treatment optimization program. Those are group medicine visits, pre-treatment, where you come in, you review all your labs. We look at your measurements, how you move. There's a functional medicine or a eval there. They start to address the biome, the gut biome. They start to look at, hey, is there some rheumatoid stuff going on? They start to talk about hormone replacement in men and women, which is vital. So yeah, I mean, we're trying to do right by our patients, number one. And yeah, when you get into something like this, if you're new to it and you get a patient better, it's a really great feeling. But I will caution everyone, karma's a bitch. And if you start to get a little big for your britches and treat everyone, you will go down hard. And, we all make mistakes and we learn from them. The only thing you can do is learn from them and not repeat them. And so we're trying to get really good at not treating people we can't help.
Being humble is the number one thing. Yeah.
Can you maybe walk us through this case?
I mean, do we want to grab the camera?
Yeah, bring it.
I can bring this over.
Yeah, there you go. Perfect.
Yeah, so here's our ultrasound.
You're good right there.
Okay, so in this image, so like when you see an ultrasound, this is like a GE super expensive high-end ultrasound, of course. But so like to the left here is our young lady's head. To the right is her feet. So this is her femur coming down with a tiny bone spur off her femoral condyle right there. Here's the tibial plateau, tiny bone spur. Skin is on top, going through subcutaneous fat to the capsule. Remember when I made that stalactite or stalagmite comment with the capsule running over that? So this capsule is a heck of a long way from that spur. Now, if you have grade 4 OA with a huge spur going up like that, that's where you worry about that capsule. But look at this meniscus. So the joint space is from here to here. The meniscus is extruded up and out of the joint. I'll get my pen out of there. But this meniscus tip, the tip is on top here. This should be equal to between here. So that's like one of the first, second or third step that happens in an osteoarthritic progression is your meniscus moves out of the joint. So if this pad isn't between these bones down here, it's less of a cushion. And that's part of your arthritic progression. She has a horizontal cleavage tear in her meniscus. This dark, you may not be able to see it on the resolution of your camera, but there's a dark line from there to there. And the gray here that's really homogeneous is healthy meniscus tissue. So I put a needle right in there and I put adipose and bone marrow stem cell with platelets right there. Then I put a pillow within this capsule above the meniscus and above the capsule between the soft tissue in there. Let's see. Do I have another picture here? Here's just another pic. We just changed our view here, but you can see down into the joint. I think one of these you can see actually. There's the needle coming in, but it's not great. So this is great television, right? Great, Doc.
Great podcast here.
Yeah, great podcasting. Here's the needle coming in. So here's my needle coming in. In this view, we're doing a suprapatellar bursal injection of just getting it in the joint. This is what a needle looks like on ultrasound coming in. And this is how hard it is to inject a knee that's not swollen. So here's skin, subcutaneous fat, quad. The quad stops right there. The prefemoral fat pad is this big hunk of white stuff. It's like synovial prefemoral fat pad. If I put my needle too deep, that hurts. So I want to be right between there and there with that needle tip right there. And that's, it's easy to do if you've done 10,000 times. But
precision.
it's important. So anyway, that was a horizontal cleavage tear in a 57-year-old woman I treated from your neck of the woods.
Yeah.
Can't wait to see how she does. It'll be exciting. She's one of our people. She's 57, probably looks and acts 47.
Right.
Very healthy, fit, hard worker. By all intents and purposes, should have a great outcome.
Awesome.
Beautiful.
What about, I wanted to ask you about like osteochondritis dissecant, which can be like really pesky, like elbow and knee. What's your outcomes with that? And
I don't treat that in the young athlete because rest works.
Right.
So I always want a MRI arthrogram in those cases because you got to figure out, is that little piece of dead bone cartilage stuck there, or is it floating? Is it stable or unstable? If it's unstable, they got to be cleaned out. Like, I don't play surgeon. Like, they need to go see George and get that elbow cleaned out. If it's stable, the data is that they will heal with rest.
Right.
And that bone can reestablish that blood flow, heal that, and then most of them later in life don't have any problem with their elbow.
Right.
So one of my biggest bugaboos is, we joke about it, but like the baseball dad, who's the coach.
Dumbass dad.
Yeah, dumbass dad. And they're paying a lot of money to be on a team, and they got to throw weighted balls at 11. Ta-da, here you go. Here comes your elbow injury. There's so many organizations in St. Louis that do this. It's staggering.
Yeah.
It's crazy. I love weighted balls when you're 18, 19, 20, playing college. When your elbow's developing and you're not skeletally mature, it's a really bad idea. Takeaway right there.
Pro tip.
Yeah, right. So I don't inject those at all. I never have, and I never am going to, because I just feel like nature, if you give that kid 6 months of rest, he's going to grow. He's going to hopefully be okay emotionally. That's a big deal. But, dad's going to come down a bit, and the kid is going to be fine long term. I don't like to alter biohack the elbow in 13 or 15-year-olds. I will do that in a tendon or a ligament because I know it works. And they've got an injury, OCDs are probably up there with athletic pubalgia. That's a really hard diagnosis. And by the way, WashU has a wonderful OCD center of excellence down there. I use them. I'm like, they're smarter than me. Like, go there. Like, that's not really my bailiwick, Sure. But it's my job to diagnose this and make sure they get there.
Right. Sure. Right.
Awesome. Well, we kind of just tip of the iceberg of regenerative medicine, which is what we wanted to do. We wanted to literally kick this off, and then we're going to have more episodes like this and kind of delve into more topics, I'm sure. And so if you enjoyed this and you have specific questions that maybe we didn't cover, send them in. That way we have a little bit more pointed topics going forward, and kind of can't answer some of your questions. It's a fascinating field. It's something that Brett and I, we talk about a lot. Like it's like the wild, wild west in a good way, because it's new. We can't wait to learn more about it and use it more. And so anyway, we thank you for educating us, number one. And where can people find you? And what's the website and stuff like that if they have patients they want to send you, or they have questions for you, things like that.
I mean, first of all, thank you very much. It's always fun. My mom told me I have a face for radio, so hopefully the camera caught my good side.
Yeah. You look perfect.
Love talking. Bluetailmedicalgroup.com is our website. My Instagram, I hired a PA, Paige Rockers. Shout out to Paige. She's like young and hip and so smart. And I created this Instagram page. It's Matt Bays MD, and Paige runs it like a rock star. So I love, we put fun cases up there. So I got to give it a shout out. But
sweet.
Yeah.
That's perfect. That's awesome. Yeah. We'll link it in the bio.
My first 50 followers were my daughter's sorority sisters.
Potential patients.
Yeah, that's right.
Hopefully not for a long time.
Yeah, that's right.
I am not hip on this.
All right, Matt, thanks again. Bluetailmedicalgroup.com, and we'll catch you guys next time. Good luck with patients.
Thank you.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.